Thymic abnormalities in myasthenia gravis. Thymic lymphofollicular hyperplasia occurs in 65% of myasthenia gravis patients. Thymoma occurs in 10 to 15% of these cases. Thymic enlargement may be missed on a chest X-ray. Contrast enhanced CT scan is essential for evaluating the thymus gland. Thymic hyperplasia. The marked hyperplasia of the thymus occurs in thymic medulla, which is common. It is characterized by lymphoid follicles and active germinal centers. It occurs commonly in younger patients, usually third and fourth decade. Thymic tumors, that is thymoma. They have two major histological forms, histocytic type and lymphocytic type. Some tumors contain spindle-shaped cells. Mixed histological patterns are also common. Thymic tumors may show sudden remission of symptoms, severe relapses, and drug resistance. Thymoma may occur without initial myasthenia gravis symptoms also. Myasthenia gravis can develop years after tumor removal also. Spread of thymoma. It usually spreads locally within the mediastinum. Regional lymph node involvement may occur. Distant metastasis is very rare, but when metastasis occurs, lungs and liver commonly involved. Pathology in myasthenia gravis. Brain and spinal cord usually normal. Muscle fibers are generally preserved. Severe cases may show segmental necrosis and regeneration in the ocular, diaphragmatic and esophageal muscles. Neuromuscular junction changes. Major ultrastructural abnormalities occur at the motor end plate, that is, simplification of the postsynaptic membrane, reduced synaptic folds, widened synaptic cleft. Presynaptic vesicle and acetylcholine quanta remains normal, suggesting active degeneration and repair process at neuromuscular junction. In this figure, we can see first image, end plate from a patient of myasthenia gravis. The terminal axon contains abundant presynaptic vesicles, but the postsynaptic folds are wide and there are few secondary folds. The loose junctional sarcoplasm is filled with microtubules and ribosomes. The synaptic cleft is widened. Second image is a normal end plate for the comparison. Neurological disorder associated with thymoma. Thymoma may be associated with limbic encephalitis, midbrain encephalitis, Morvan syndrome, aplastic anemia. Some linked to antibodies against voltage-gated potassium channel (VJKC), indicating an autoimmune or humoral immune mechanism involving autoimmune diseases associated with myasthenia gravis. There is increased association of myasthenia gravis with hyperthyroidism, systemic lupus erythematosus, rheumatoid arthritis, Sjogren syndrome, mixed connective tissue disorder, polymyositis. Some patients show positive ANA without a clinical lupus. Thymectomy indications. It is recommended for generalized myasthenia gravis, that is, between puberty and 55 years of age. Performed electively during the stable disease. It is not usually required in isolated ocular myasthenia gravis. It is indicated in nearly all the patients with the thymoma. Benefits of thymectomy. Approximately 35% complete remission. 50% will have partial improvement. Best results when surgery is done within 1 to 2 years of onset of symptoms. Response develops gradually over months to years. Antibody levels may decrease or disappear after the surgery. Evidence supporting thymectomy. Randomized trials show there is reduced prednisone requirement, fewer medical complications, better outcomes with surgery with prednisone. Benefits are more evident in women. Clinical improvement often maximal by 6 months. Surgical approaches. Transsternal thymectomy. It's more complete thymic removal preferred in thymoma. Suprasternal or minimal invasive approach. It has less pain and lower morbidity. Surgery should be performed in specialized centers only. Perioperative management. Preoperative plasma exchange or IVIG may help in weaker patients. Postoperative respiratory support should be available. Neostigmine may be given intramuscular postoperatively. Oral medications are resumed gradually. Thymectomy in elderly patient, it can be safe and beneficial only in selected elderly patients. Improvement is less predictable due to thymic atrophy in elderly. Some patients above 60 years still benefit the surgery. Management of invasive thymoma. Complete surgical excision is preferred. Residual tumor is treated with radiation therapy. Chemotherapy options include cisplatin-based regimens. Survival benefits from chemotherapy remains controversial. Key take-home messages are thymic abnormalities are central to myasthenia gravis pathogenesis. Thymic hyperplasia and thymoma are common in myasthenia gravis. Motor end plate damage is the main pathological lesion. Myasthenia gravis is strongly associated with other autoimmune diseases. Thymectomy improves outcome in generalized myasthenia gravis. Early surgery provides best remission rates. Complete thymoma removal is essential for the therapy.